Thanks, Matt. It's really nice. I see some old friends in the room and some relatively young friends. They're all relatively young, but thank you. Okay, so I'm going to be talking about managing challenging hypertensive patients, and there's going to be just a little history in here because the people that know me know that I've been doing hypertension since 1986, and I became interested in central blood pressure. Well, let's back up. You're going to hear about that in a minute. I think the important thing is that we've got standard physiology texts that teach blood pressure is determined by cardiac output and total peripheral resistance. However, this neglects the effect of arterial stiffness, which is an important factor in isolated systolic hypertension, and as you will see later on, systolic hypertension in the older folks and in the younger folks. So just to review the components of the blood pressure in the arterial waveform, let's see, somewhere here. Oh, there we go. Beautiful. I like that. We have the systolic, diastolic pulse pressure, and of course the mean arterial pressure. An elevated pulse or systolic pressure is due to an elevated arterial stiffness and or stroke volume. So just to remind you, in young and flexible arteries, you have a very different waveform than you do in older, usually older, stiffer arteries. Obviously, it isn't about age, it's about chronological age, because those of us in this room that are practicing nephrologists, and I see many of us, have plenty of young folks that probably have waveforms similar to this who are on dialysis. So the effect of stiffer arteries is to reduce myocardial perfusion, increase left ventricular afterload, and therefore, of course, LVH, and increase central systolic and pulse pressure. So if we want to measure the impact of arterial stiffness on blood pressure, just let's remind ourselves again about the pulse pressure, the augmentation pressure, which is the contribution of the reflected wave to the pulse pressure, the augmentation index, which is the percentage, this is derived, this is a percentage of the pulse pressure due to the reflected waves. And the influence of arterial stiffness on blood pressure can be readily assessed from the central pressure waveform, and this is very simple to do. And these pressures indicate the extent to which the wave reflection and arterial stiffness contribute to hypertension in a given individual, and it can make a difference in how you treat a patient. So in terms of the information for hypertension management, analysis of the central pressure waveform provides this information and may influence our choice of antihypertensive medication, and this, as we have more objective data, is going to make it that much easier, and the relative impact of antihypertensive patients. And as a practicing resistant hypertension specialist, which is where I use this the most in my hypertension clinic, I do a lot with pre and post intervention looking at the central pulse pressure and the central systolic blood pressure. So what does the brachial pressure miss? This was the point at which I became interested. I didn't even know about this technology until I started reading about the ASCOT trial. The ASCOT trial, as you can certainly remember, it had several different branches, but there was a lipid-lowering arm. But the blood pressure arm was really a comparison of a thiazide diuretic and atenolol versus amlodipine and perindopril. And blood pressures were essentially equal, brachial blood pressures. But when a sub-study was performed that looked at central pressures, your central aortic pressures, with a combination of the ACE and the CCB, were statistically significantly lower, and associated with that were improved outcomes. Slide not provided, but you can certainly go back and look at the data yourself. And this was really the first clue that central blood pressures might really provide us with additional information that was clinically relevant. So I just wanted to mention that in terms of the effects of antihypertensives on central blood pressure, I just want to point out that non-vasoactive beta blockers, and that would be things like atenolol, which is very rarely used anymore, and also metoprolol, are both what we would consider to be non-vasoactive, and they tend actually to increase central systolic blood pressure disproportionate to brachial blood pressure, not increase, but the difference. Diuretics tend to be neutral. Angiotensin blockers and ACE inhibitors and calcium channel blockers all disproportionately decrease the central pressure as compared to the brachial pressure. Aldosterone antagonists are a little more controversial, so I'm just telling you they're controversial. But interestingly, nitrates, which is not something that we'll typically use for hypertension, nevertheless has a very significant effect on central pressures. And whether that's part of the cardioprotective effect we see with the combination of nitrates and hydralazine, for example, in heart failure, I don't know, and perhaps Dr. Budoff can help us out with that. So let's talk about a couple of real-world patients, and I will tell you that I do use this frequently in my practice, and it often is helpful to me in both younger patients and in terms of seeing a change in terms of a very high pulse pressure, central pulse pressure, to a lower pulse pressure, which makes me happier, or a lack of change going, oops, I need to use something else, or intensify my therapy. So this is a 52-year-old diabetic. We've got a blood pressure, brachial pressure in the office of a 138/72 with more than 1 gram of proteinuria. So according to our current guidelines, we'd still probably want to intensify therapy. So the answer is yes, we want to treat this patient, but what antihypertensives would we recommend using? Well, when we did the central waveforms in this patient, as you can see, we've got a central pulse pressure above the dreaded 50 millimeters of mercury, and we know that we've got to reduce that. As well, we have an augmentation pressure that indicates significant arterial stiffness, very upper range of normal, augmentation index in the normal range, and suggests that it's not just stiffness that's causing the problem here. So the augmentation pressure suggests that we should be using a vasoactive drug, an ACE or a CCB, in order, hopefully, to disproportionately lower the central pulse pressure. And after 2 weeks of treatment, the brachial pressure was significantly reduced. The central and systolic and pulse pressure were also significantly reduced, below that magic number of 50. So let's talk about another person. Let's talk about a 41-year-old male with borderline isolated systolic hypertension. So should we treat this patient, and if so, what should the treatment be? This might be a familiar slide, but actually it's not. So what we have is we have a brachial pressure of 142/64, but the central blood pressure is quite a bit lower. The central pulse pressure is within the normal range, maybe a little on the high side. But we have an augmentation pressure of 0 and an augmentation index of 0. Now, we don't have terrific data about what to do with a 41-year-old. Most of the data that we have in terms of outcome data in treatment of hypertension is in patients who are slightly older. I'm not sure if this patient were 41, I'm not sure that I would necessarily have the courage not to treat them, but based on this data, it looks as if they don't necessarily need to be treated, or they need to be treated with diet and regular exercise, because we know in patients, even with resistant hypertension, that regular exercise will significantly lower the blood pressure if the exercise is sustained. But if we changed this person's age and made him 31 or maybe 29, and we shifted his central pulse pressure to, let's say, 40, then I think you could have a very good argument for saying you want to follow this person, you want to treat them with non-pharmacologic means, because we just don't have the data in someone with normal renal function to treat the blood pressure. In the absence of diabetes, to treat the blood pressure at that age. We don't have the outcome data, which suggests to me that in addition to everything else, that central pressures are hypothesis generating and mean we need to do more research. while we're figuring things out with our patient, we need to do additional research. And the points to be made from this are that because we have a low augmentation index and augmentation pressure, that vasoactive drugs are likely to have less than expected effect on arterial stiffness, and an approach, I wouldn't call it a less aggressive approach, I would call it a non-pharmacologic approach, such as exercise and lifestyle changes, are what I'd be looking for in this individual. So drug therapy was not prescribed, and as you can see, the numbers became much more normal because this is someone who actually sustained their exercise effort. And I actually saw a patient in my clinic on Tuesday who was 28 and a resident at the hospital and had exactly this type of picture on his central pressure waveform. And I am going to be advising diet and exercise and follow-up for this gentleman rather than initiating an antihypertensive drug at the ripe old age of 27. So now let's talk about one more. We have a couple more, and we're gonna get through number 4. And if everyone has patient fatigue at that point, we'll stop, and otherwise we'll keep going. So we have a 65-year-old male with borderline isolated systolic hypertension with a blood pressure of 140/80 in the office. And again, I have to put in a plug for home blood pressure measurement in all of your hypertensives, and for our future set of slides that we include some home readings for intellectual interest's sake, since we all advocate this for our patients. So the question with this appropriately measured office reading, maybe with BP True, is should this patient be treated for hypertension? And if so, what should the treatment be? Well, let's consider the additional information that we've received. We've got a brachial pressure of 140, but look at the central pressure. I think now you're going to be seeing some lines of identity here. We've only got a 4 millimeter difference. That is to say, the central pressure is significantly higher than one would expect it to be if there was not some arterial stiffness. Too many negatives. Basically, we've got a central pulse pressure that's really above the danger zone and an augmentation pressure significantly elevated. So again, the high augmentation pressure and augmentation index indicated a strong reflected wave and a high level of arterial stiffness. And the high pulse pressure indicates significantly increased cardiovascular risk. So after considering this information, would you treat this patient? If so, how? Well, of course you'd treat him. But again, we've got an argument for using drugs that we know are going to disproportionately decrease central pulse pressure, and that would be ACEs and calcium channel blockers. So now, we've got a 35-year-old male, so that I think is pretty clear. Oh, the other thing I might mention is that as you saw from Matt's slides, even though we talk about beta blockers not decreasing central pressure, that's more traditional beta blockers, atenolol, metoprolol, whereas drugs like bisoprolol do, and I think we have, I'm not certain about the data with carvedilol, but I'm sure someone can help me out with that. So we've got someone with blood pressures that are still within the normal range, but really high normal. We'd call this pre-hypertension. Should this patient be treated, and if so, what should the treatment be? And again, this presupposes no diabetes, no chronic kidney disease, no proteinuria. Well, let's look at the central aortic waveform. And as you can see, we've got a brachial pressure near hypertension, but the central and pulse pressure are well within the normal range. And the low, again, the low augmentation pressure and augmentation index indicate little effect of wave reflection. Look at this, -10, -3. The young gentleman that I did the central pressure on in my clinic on Tuesday had an augmentation pressure of -5. I'd never seen that because 90% of my patients are 65 with systolic blood pressures of 190, not people that are coming in with what I would consider to be moderate elevations of blood pressure and much younger. So with this, what would you do? Well, again, I think non-pharmacologic therapy, exercise, DASH diet, etc., are appropriate ways to proceed in this situation. So, case number 5, and then I think we're going to stop, is a 60-year-old female with a blood pressure of 158/80. Initial medications include irbesartan, prazosin, and indapamide. I have to say, in my own practice, I use very little prazosin. If I'm going to use an alpha blocker, I'm going to use something that's even a little longer acting, such as doxazosin. But again, that's a third or fourth line drug. How should this patient's hypertension be treated? Well, let's see what the central pressures look like. And as you can see, when we look at the central pressure, we have we have an elevated central blood pressure. We've got a high pulse pressure, again, and a very high augmentation pressure. So we're going to go ahead and do that. Now, what was started on this patient, I have to go through here, verapamil was used, and although there was improvement in the central pulse pressure, it was still somewhat elevated. So the question is, would you have chosen to increase a diuretic rather than add another drug? Probably not. Would you add a vasoactive beta blocker? Possibly. Would I replace the alpha blocker? Possibly, but probably what I would do would have been to use a drug like amlodipine, which is probably a little more potent at full dose 10 milligrams than verapamil 180 milligrams. On the central pressure. That's what I would have done, but there are other arguments for doing other things. But the point is that, by and large, as we know now, thiazide diuretics don't disproportionately lower the central pulse pressure. I think, do we have time? Do you want to do one more? No, we can stop. All right. So, and first of all, I want to thank everyone for being awake through this litany. I want to emphasize that I'm fortunate enough to be able to do research, but I do lots and lots and lots of patient care, as some of my colleagues know. And I really do find that in my resistant hypertension clinic in particular, that this is very helpful, and it's also something you can show the patients and go, look at this. This we know is associated with an increased risk. We're going to try to reduce your risk, and we can measure a follow-up in 6 weeks to 2 months and see whether we're making improvement or not in this additional parameter. I also think that this is a real opportunity for additional research as well, particularly in younger patients with low central pressures where perhaps they don't need to be treated with pharmacotherapy, but we are not sure of that. It just gives us some hypothesis generation and more clinical trials to perform. Thank you very much.